CMAAO International Weekly Session. We are joining in. And today we have a very, very important topic and a very important speaker joining in from the airport, especially to give us an immense knowledge on diabetes.
Yes, thank you, Saurabh. So I'd like to, just with great pleasure, that I'd like to introduce Dr. Banshoo Saboo, who is a distinguished diabetologist and an influential leader in diabetes research and education. He currently serves as the chair-elect of the IDF Southeast Asia and vice president of the Diabetes in Asia Study Group, or the DASG. His leadership extends to various prestigious organizations, including Diabetes India, the Indian Academy of Diabetes, RSSDI, and AIAARO. A globally recognized expert, Dr. Saboo is the founder of Detect Diabetes Care India, an NGO, and the India Suite Registry, contributing significantly to diabetes care innovations. He also serves on the Global Advisory Council, EASD, and the advisory group of the American Diabetes Association of the ADA. With over 150 publications in index journals and editorial roles in leading diabetes textbooks and journals, he has shaped the academic landscape of diabetes care. His dedication has been honored with fellowships from the American College of Endocrinology, the American College of Physicians, and the Royal College of Physicians, Glasgow, Edinburgh, and London. Dr. Saboo's outstanding contributions have earned him prestigious accolades, including the Most Impactful Healthcare Leader Award and the Global Clinician of the Year in 2024, as bestowed by the AACE and in the United States. He is also the initiator of the RSSDI Defeat Diabetes campaign, which set a world record with 1.2 million diabetes screenings on World Diabetes Day. It is my pleasure to introduce Dr. Saboo, who is going to discuss a very important topic and of a very prevalent condition. Welcome.
So this was Dr. Monica from US. Dr. Saboo, over to you. I think we have lost the connection for Dr. Saboo. He will be joining in. He's joining in from the airport, so I think we have a little glitch in the connection. So we'll wait for him to join back. Meanwhile, Dr. Monica, would you like to say something on diabetes? I think it's a very important topic. India is known for a diabetic capital of the world. So I think one of the very important topics we need to cover.
So diabetes and insulin resistance is a condition that affects our patients, but it also affects us and our families equally. This is a condition, whether or not we treat the disease or we are clinically involved in the disease, knowledge about the disease will help us take care of ourselves and also the other conditions that we treat that can be impacted by this. We know that medications that we prescribe to treat other conditions can affect diabetes control. We know the effect of lifestyle changes on the effect of diabetes, which also affects the other conditions we may treat, such as hypertension or asthma or other metabolic conditions. And I think in the age of where there's many more medications available for the treatment of obesity, we are recognizing that the multitude of medications available in conjunction with lifestyle modifications, dietary changes, exercise, it's
Really
very
sorry, I don't know how it was disconnected.
a holistic approach.
Also, my
No problem. So we have our speaker back, and we will start the presentation.
can you see my slides?
Yes, sir, we can see that.
Right, great. So what I'm going to talk in next 30 minutes, type 1 diabetes care, where we have come from and where we are going. I don't have any financial disclosure for this particular presentation, but I'm actively involved with all the activities which are helping people with diabetes, particularly type 1 diabetes. Maybe it is SPAD, Life for Child, Changing Diabetes in Children, Type 1 Diabetes Network, or Juvenile Diabetes Research Foundation. Recently, Government of India put me in Technical Committee of Diabetes under Health Ministry. We know that type 1 diabetes seen in India before 30 years. At the same time, DCCT was published in 1993. At the same time, I also started my journey in field of diabetes from 1995 to 2025. Over a period of 30 years, there are a lot of things which is changed. At that time, the urine monitoring and blood glucose monitoring in lab before 30 years in our diabetes clinic, that was only thing which was available to us. Urine ketones and urine sugar strip was available for monitoring of these patients. Very occasional use of self blood glucose monitoring by person with diabetes. It used to be, we used to have only one glucose meter in the Department of Medicine. A1C was not for everyone. Even we were having a World Health Organization supported lab in our medical school. But for each and every patient, you have to justify why you want to get A1C for that patient. There was a regular follow-up, but it was really a dream to have a same patient who is coming to you regularly. And most of the time, the resident also used to see randomly the patients. No records and no data keeping was the system. An annual screening for complication after 5 years of diagnosis of diabetes was also not done for most of our patients. Today, when I'm in a private setup, it's a tertiary care center with 2,000 people with diabetes who are type 1, who are on regular self-monitoring of blood glucose. They are having A1C every 3 months. Few of them are on continuous glucose monitoring. We do their annual screening, and we have full records at my clinic of almost 25 years. But at public hospital, still a lot of things has not changed in last 30 years, except you can say now, instead of urine glucose monitoring, they might be doing with blood glucose monitor. If you see the type 1 diabetes incidence, India is not the country where we have very high incidence. Rather, we are at a less than 5 per 100,000. While in North Europe or North America, you will find the incidence is much higher. Even in some parts of the Europe, it is more than 30 per 100,000 people. But still, if you see the ID of data, International Diabetic Federation data, in 2021, we have 229,000 people with type 1 diabetes below the age of 19, which is highest in the world. At the same time, we add 24,000 newly detected type 1 every year in this list. So that's again highest in the world. But still, we are not top 10 countries who have highest incidence per 100,000 patients. We are much less. But there are some Asian countries like Saudi Arabia, Qatar, and Kuwait. They are found to have higher type 1 in compared to other parts of the Asia. Diagnosis of diabetes in children was like 100 years before. If it was diagnosed, it's like a death sentence. Then we realized this happens more in the younger people. We started calling this type 1 diabetes as juvenile diabetes. Later on, we started understanding that all who are diagnosed with diabetes may not have type 1 diabetes or insulin deficiency diabetes. And we started treating them oral hypoglycemic agent in last 60 years. And then some of these non-insulin requiring young person with diabetes, there is a possibility they are having type 2 diabetes. And because of increasing incidence of pediatric obesity, this type 2 diabetes in young population is also increasing. This is DCCT trial. To get and achieve a tight glycemic control, there was a hypoglycemia, and that risk of hypoglycemia was very high to achieve a tight glycemic control. But over a period of time, when DCCT was over, the intensive therapy, they could achieve the mean A1C of 7.2, but conventional arm was still at 9.1. While the post-DCCT, the ADIC follow-up, the HbA1c difference between these two groups was diminished. It had become intensive arm become 7.8, while conventional from 9, it has decreased to 8.2. So that's what the people who were in a conventional arm, they started understanding the importance of the tight glycemic control, while the intensive arm, They were in the clinical trial, they were very intensive in that, and later on, they slightly got relaxed. But this intensive therapy of 6.5 years, then followed up for another 20 years, found that they have lifelong less cardiovascular disease also in compared to the people who does not have uh, tight glycemic control or those who are not having intensive control of diabetes. The problem is the first occurrence of MACE is not happen in first 10 years of type 1 diabetes. And that's the reason people mostly who are seeing type 1 diabetes in their earlier course of diabetes disease, they are not very aggressive or intensively treating these type 1 diabetes. Because the difference between conventional treatment, intensive arm is seen after 10 years or 15 years. That's what we have. But what's the goal of managing diabetes? One, definitely they should have near normal blood glucose level and A1C level. They should not develop hypoglycemia, no diabetic ketoacidosis, good quality of life. They should achieve normal growth and physical development and psychological maturation. And we have to establish a very realistic goal that is adapted to each individual circumstances along with love and care. The diabetes management, which is done in a clinic, is hardly 15 minutes for once in a 3 months or 6 months, while the patient has to manage it 24 by 7. Not only patient, the caregiver. And they have to constantly juggle between insulin, medication, exercise, food intake, calculating the carbs, checking their sugar, and taking insulin accordingly. We have the data to support that. A person who is checking sugar more times and taking more bolus shots, like more than 5 to 7, you will find their A1C is much better control in compared to the people who are taking only 2 to 4 shots a day. This is what the DCCT chairman talked before almost 23 years before, that the intensive diabetes treatment is not just more insulin. I mean, just giving the insulin extra will not get them at a tighter control, rather it can increase the hypoglycemia. Try to titrate the dose along with lot of education. That is what is required. This is a pic which was put on a social media just to uh, keep everyone aware that how type 1 diabetes is. It is like taking 1460 shots in a year to stay alive. Even this child may be on continuous glucose monitoring and pump, she might not be taking, but just to explain everyone that a type 1 diabetes is how serious disease and how seriously people should take it. This is what a one paper which is written by us about the type 1 diabetes awareness and management challenges and the current scenario in India in last 15 years. Because this paper is before 15 years, nothing has been much changed. Because this is a paper of 2022, which talks that the person who develops type 1 diabetes below the age of 10, the roughly survival, a good quality of survival for that patient is around 18.7. That's the what mean age for them to have. And then later on, they develop complication, maybe for uh, diabetes, microvascular complications, which are very common in this population. How does India compare? It is comparable with Sudan. It comparable with some third world countries where uh, care is maybe suboptimal, but other countries where the captain is supraoptimal or the extraordinary, where it cannot be compared. The person who is surviving in India averagely for 20 to 25 years. Why does India look like this? No care, ration, pre-mix insulin, that's very, very common, putting them on it twice daily. That what they think is sufficient. People don't monitor 4 to 6 times, they don't take prick, they don't carb count, they don't take the uh, correction dose, and that's the reason they don't uh, keep their A1C below the 7. Managing type 1 diabetes is a standard. This is last 30 years, nothing has been changed. Basal bolus, self-monitoring, diabetic education, and regular follow-up. And that is what is required. But still, the challenges are continuously remain high in Southeast Asian population. This is a paper before 5 years talking about we have a lot of challenges to put or aggressively control these type of children. And at that time, before 5 years, when we have returned, the technology was not so advanced as we have today. So the key challenges in the provision, definitely low awareness, so late in diagnosis, misdiagnosis, sometimes they are unwilling to intensify therapy, initial treatment management, even it is not available at the primary care level, and person who is living with diabetes, If they have adequate knowledge of technology, if they can counsel the other people, nothing like it, because that's like a social worker. But there is a lot of stigma. People don't want to tell that I'm having type 1 diabetes. Now, this is the situation. Where are we going? Now, before 7 years, in 2018, we have done one World Congress of Pediatric Diabetes. It's very famous meeting in Europe and US, but first time they had come to India on a request, and I was the part of advisory council. Then we had also become the part of Sweet Registry, which is an international registry group of more than 50 centers from India and Asia, where I am hub leader. And we had become first time outside US as a part of this particular program, and keeping all our patients' data along with SPAD registry. After that, in 2018 onward, if you see any time in SPAD guideline, you will find some of our people names are there always for this. The same phonetic of blood glucose do not show the full picture. Even somebody is doing 3 times, 4 times, 6 times sugar, still does not mean that their sugar report, even if out of 4 or 3 are okay, are they doing good? No. If you put them on continuous glucose monitoring, you will find them they are developing actually midnight hypo also. So, by continuous glucose monitoring, you can modify therapy in a very perfect way, in a very precise way, and that is what we want. But what the evidence is there? The evidence is that those people who are in DCCT, you can see the 62 per 100 patient. While the people putting on CGM, the risk reduction from 62 to 20 per 100 patients here. This is what the international consensus on use of continuous glucose monitoring. I was part of all those experts who are there, and we have written that all insulin deficient diabetic patients should be on insulin pump. And then if you are on continuous glucose monitoring, probably you need a better marker of your control instead of HbA1c, which is going to give you the prediction of last 3 months. While continuous glucose monitoring, you can find that in last one day, how much time you remain in good control. And that's what the recommendation is. More than 70% of the time, somebody should remain in time in range. But by putting the patient on continuous glucose monitoring, one more phenomena which we started seeing in type 1 diabetic patients, particularly, sometimes the same patients on a day 1 and day 3, or day 1 or day 2, behave completely differently. And that too, if, if middle of the night, then it means we have to deal with these patients with an advanced therapy for these diabetic patients. Same patients we have done for 4 days, still 4 days, reports are different also. So CGM alone is not enough also. It still 70% of our patients are not achieving target optimal control, because they may achieve the target, but they are developing hypoglycemia also. Pump, there is an advantage. The pump has over MPI, because it can be different basal dose and bolus dose can be given with the pump therapy. So that's an advantage for this. There are practical issues. One major challenge is the cost, but other than that is the awareness about the food and habit also. In 2019 only, the automated insulin delivery written by American Diabetes Association, they wanted the people who are really in need, they should be on sensor augmented pump therapy. So what's the advantage of putting the person on sensor augmented therapy? The sensor augmented pump had shown after almost 30 years, in 2016, 1983, when Yagnik sir had started type 1 diabetes, uh, along with other people. But this is in DCC trial in 1983, 2016. After 25 and 8 is almost 33 years later, 2016, this paper pivotal trial had shown the hypoglycemia rate, which was like 62 per 100 patients here, is reduced very, very significantly, and it had become the mean A1C of these people from 7.7 to come to 6.9. If you put your patients on an MDI with blood glucose monitoring or CGM, or a patient's putting on a pump without augmented sensor augmented pump therapy, you will find most of them are not actually achieving time in range. But the people who are on advanced insulin hybrid closed loop system, you can find they are actually achieving their time in range more than 75%. This is what in India we have already crossed more than 1,500 patients on advanced hybrid closed loop system. And we have written a very recently an article, a call to action. And we recommend that the following model language be incorporated into current and future guidelines, and to the professional society and government agency, that yes, All people with type 1 diabetes must be given a choice of putting on AID, and if they don't want, then it should be also documented. The device should be made based on the individual circumstances and lifestyle, because there are other device companies who are available in western part of the world, not in India. National healthcare system should prioritize provision of this access to AID to democratize the known benefits of AID benefits. Now, going beyond that, this is almost cure. At this point of time, we try to put all our patient on advanced hybrid closed loop system, but we are looking for a cure. That one is we can put the patients on a beta cells. Beta cells can be given, but a good cell source should be there. Then they should be survived, and they should be protected too. The stem cells derived cells can be done. It is scalable. It is unlimited source of beta cells are available, but still not successful or not as a standard of care. But it had come in a phase 3 trial because they are encapsulated. So targeted immune system also get modified, and gene editing is done in these microspheres. So there will not be any reaction for these patients, and the beta cells will survive too. There is a recent advances now in 2024. There was the first person to receive this engineered donor cell for the aware of the immune system in making insulin. And there is a one company, Lentidra, remains the only approved US FDA therapy. Very short supply is there at this point of time. The Vertex, the other company who had come, they had already done their phase 3 trial and going to start their another phase 4 program too. These many companies who are involved in the beta cell replacement therapy by different companies. We know that type 1 diabetes progresses in 4 stages. Unluckily, we are diagnosed with stage 4 or late 4th stage 2, but we can diagnose people easily with stage 3. But if we can diagnose them at stage 2 or even stage 1, probably we have a cure for type 1 diabetes. Early detection program is going on all over the world, whether it's Europe, whether it's Qatar, Australia, whether it's USA, whether it's Australia, all developed world are doing tests for their people with diabetes or with their relative. These are the 7 disease modified therapy, which is almost tried in a multiple patients in phase 3 or phase 4 program. Teplizumab is already US FDA approved, and a person with type 1 diabetes with early detection of autoantibody, they can take the benefit of teplizumab also. It's a disease modifying therapy. There's no doubt about it. The first time a therapy had come, and maybe a very exciting, we all are excited that we will find in our lifetime a cure for type 1 diabetes. Even though teplizumab has shown promising results in preventing disease progression, metabolic benefit, such as significant reduction in A1C, that has been done. There is one more new molecule, which is KD-sagliatine, which is of TTV Therapeutics, found to have effect in type 1 diabetes. Every day they have to take orally, and this is what they have claimed. The clinical care for type 1 diabetes is definitely changing, treated mainly in resistance. While tomorrow we have to treat with autoimmune condition, at present we are treating with insulin hormone monotherapy. Future may tell about other monotherapies can be used for them, and disease burden is very, very high, and we have to think of something which can give them disease modifying therapy, and a first shot of injection is already being given in US population too. So DCCT insights remain very critical in shaping type 1 diabetes care, establishing a robust type 1 diabetes registry, expand subsidies in healthcare coverage, enhance public awareness and reduce stigma, scale up AID system and CGM adoption. India has become a potential to become a choice level model for managing type 1 diabetes in resource constrained setting. To know more about type 1 diabetes, we have dedicated meeting of type 1 diabetes that is on 6th and 7th. While those who want to know for the newer therapy and technology, please come and join us on 9th to 11th May at Jaipur. Thank you. Thank you. This is my team. And I mean, these are the all international body who are supporting us. And this is our team of type 1 diabetes, which are working along with me in type 1 clinic. Thank you.
Thank you, Dr. Saboo, for your presentation, your immense knowledge on the topic. We have Dr. Chong as well here. Dr. Chong is the chair for CMAAO. Dr. Chong, are you here?
Hi, Sarab. Sorry, I'm driving. But thank you, Dr. Saboo, for your wonderful presentation. Enjoyed it very much, and it's good to get an update on the latest therapies, especially gene therapies on type 1 diabetes. Hopefully, we can find a way forward. Thank you very much.
Thank you.
So we will open the floor for the question answers. If anybody has questions, please go ahead and ask or raise your hands. Meanwhile, Dr. Angelica, you were saying something. Would you like to say comments over here?
We'd like to thank Dr. Saboo. That was very interesting. And yes, we know that diabetes is on the rise, and it is a challenge to treat the children. Even in South Africa, it is very difficult. The cost involved, and it becomes, in the end of the day, a family problem. It's not only the child; it's the whole impact it's got on the family. And I think that these newer molecules and what you are talking about might change some of their lives. However, whether it would be possible in a country like South Africa, it's difficult. Yeah, and thank you again for this very wonderful presentation.
Thank you. Thank you very much.
Yes, so we will share the recordings for the presentation today. It will be live on YouTube, and I will share the presentation recording after this meeting. Anyone else has a question? Please go ahead and ask. Dr. Monica, you want to say something on it?
Thank you for your presentation, and especially while you're traveling. It was fantastic. The work that you're doing to help others is phenomenal. Kudos to you and to your team, and we look forward to having you come back for another session.
So,
Thank
Dr.
you.
Saboo, there's one question which we have is that can lack of sleep can affect the insulin and diabetes fluctuation?
So type 1 diabetes definitely have a lot of glycemic variability and fluctuation, and lack of sleep, stress level will definitely increase. But more with insulin resistance, the stress and sleep disturbance has been found to be one of the responsible reason for increasing insulin resistance and type 2 diabetes also. But definitely someone who is already diabetes, if they have the sleep issues or lack of sleep or changing, globally they travel here or there is a possibility that they may increase or decrease their insulin level, glucose level. And for them, the best thing is the insulin pump, because 780G will take care of, not only will check the sugar, but simultaneously dose of insulin will be also decided with that automated insulin delivery, and they will have a very good control over diabetes.
Can I ask my...
Sure, doctor. Sure,
Yes,
Doctor.
madam.
Okay, go ahead.
Yes, madam, please.
I wanted to you to repeat the autoimmune role in type 1 and 2 also, diabetes. Autoimmune medicine.
So autoimmune diabetes is a type 1 diabetes, while type 2 diabetes is a primarily of insulin resistance followed by beta cell failure. While type 1 diabetes is a primarily a disease of autoimmune disease. And that's the reason I had shown the later part of my talk that today we have insulin pump, that is the best therapy, but tomorrow we will have a cure for type 1 diabetes. Already teplizumab, a molecule which is a monoclonal antibody which is available to us, but that can be given as a disease modifying therapy. But
Right.
at present, we don't know very early, if early in the course of someone just develop autoimmunity, if we give therapy at that point of time, without at that time when there is no beta cell destruction is there, probably you can prevent or you can cure type 1 diabetes.
Number 2 question is number of places there is, or we see some of these soleus muscle in the calf. Does it really have a sugar lowering capability?
What you are saying? Sorry, again, please repeat.
There is a calf muscle.
Yes.
Does
Sorry,
that
yes.
have any role in control of?
So it is, yes, all muscle and increasing muscle mass definitely improves insulin sensitivity. And the people who are sarcopenic, not having sufficient muscle mass, actually have more glycemic variability and higher insulin resistance. So it's always advisable not only to go for just simple walk, they should also do the muscle strengthening exercise, because increasing muscle mass will help them and it will improve their insulin sensitivity. Dose of insulin requirement will be going down, and in type 2 diabetes it will have much significant benefit, because in type 2 diabetes patient is primarily of insulin resistance.
Right. But then there is a lot of videos on WhatsApp about
Yes.
soleus muscles in the calf,
So in
which
the calf, that muscle,
particular.
yes, so that is mainly for madam type 2 diabetes, not for type 1 diabetes.
Okay. But it does have a role, right?
It is the indirect role, as I told you, because it is improving your insulin sensitivity.
Okay. And the third being the pre-diabetes. I mean,
Yes,
how
definitely in pre-diabetes patient, it will
besides
have a help. It will be
lifestyle
like for curing them.
Pardon?
In type 1 diabetes, if you improve your muscle mass and then can decrease the insulin resistance, it will be like for pre-diabetes, they will be getting prevention of diabetes. So it's like it will help them for the prevention of diabetes.
Okay. In type 1 also.
Not in type 1, madam. It's only
Type
for type
2
1.
only. Huh?
Only type 1.
And also of course, the dietary management is very important.
Yes,
Any
very, very
other,
important.
what do you think of in, say, somebody has a 6.5 HbA1c and fasting sugar is just about 100, 206, even a little lower sometimes. And
So these are the
BP is
patient, if postprandial, madam, if it is more than 200, they should be given the treatment. If fasting is less than 110, they will require only to control the post-meal glucose level. But if they can control their diet very good, I mean HbA1c of 6.5 with a fasting of less than 110, it is only the post-meal glucose is a challenge for them. I may put them only on diet with a low carbohydrate diet and will keep them on a monitoring. That is the best way for them.
That's all. Okay. Thank you.
So, Dr. Sabu, there's a question from a lady which says, "I'm pregnant for 6 months and have a high diabetes. Is it safe to take insulin?"
Yes.
Uh,
So insulin is the safest for the person with pregnancy with diabetes, because all other molecules, all other anti-diabetic drugs, actually they cross the placenta, while the insulin is the safest and they should be given to the person who is pregnant and having diabetes. Or sometimes there is one more condition which is known as they are not having pre-existing diabetes. First time they are
Yeah.
detecting diabetes during pregnancy, what we call is hyperglycemia in pregnancy or gestational diabetes mellitus. There also the choice of therapy is insulin only.
so post pregnancy, does that blood sugar get controlled, or is that something which
Yes.
continues?
So the GDM patients who have first time detected diabetes during pregnancy, their sugar will be completely normal after the pregnancy, because that GDM is a condition where the hyperglycemia is only during the pregnancy. Once they will be delivering the baby, the hyperglycemia will go away. But for some of the patients, they may continue to have hyperglycemia and we detect them as a diabetes. Then we start therapy them, but starting with metformin, and during the lactation period, we may give sometime only insulin, because again, if any other oral anti-diabetic agents which we give, it may get excreted through the milk also, and it may have effect to that newborn.
Okay, great. Anything on the young diabetes today, considering what is happening? I think this question comes out every time.
So the young diabetes, what is autoimmune diabetes? What is that type 1 diabetes? Where the child or the family, they may have some increased autoimmunity. And that's the reason they develop a autoimmune type 1 diabetes, where 100% beta cell get destructed. So they require insulin therapy for lifelong. And now we are seeing a lot of young people, because autoimmunity is also increasing, slightly increased incidence of type 1 is also happening. and more people are diagnosed with type 1 diabetes. So we are seeing that more number of young diabetes patients which we are seeing. But there is one more condition because of increasing pediatric obesity, increasing weight, that is also responsible of getting type 2 diabetes in young population also. So that is also equally very dangerous, because for that prevention we require a lifestyle modification. Rather, pediatric obesity should be increasing awareness will help the people to prevent pediatric obesity also.
Thank you, Dr. Saboo. You've given us a very good rundown of, not just IDDM, but also other aspects of diabetes, especially affecting the pediatric population. Thank you very much for your thoughts and comments.
Thank you. Thank you.
Do we have any other questions on the floor? Dr. Saboo, what do you want to say anything about artificial pancreas? Is that something which
At
is
present, the advanced hybrid closed loop system is very near to artificial pancreas. But there is a dual hormone pump is also available, just introduced, but still the clinical trial are going on. And once the dual hormone pump will be available, it is what the advanced, it's almost artificial pancreas. That is what we were looking for. At present, this advanced hybrid closed loop system is very, very near, because it does not have the glucagon, but it has the insulin hormone, and it delivers insulin automatically by checking the sugar level. But the dual hormone, the glucagon, will also help these people if they develop hypoglycemia. So that is also will be available maybe in 2 years time. You will find that commercially it will be available too.
Dr. Saboo, I'm just curious, when it comes to these pumps, these closed loop pumps, the amount of insulin secreted by these pumps, right? How does it compare to the normal pancreas?
So it is what happens. There is a continuous glucose monitoring also simultaneously. So they check the sugar, and according to they give the insulin. But it also comes with the artificial intelligence. Every time they check your lifestyle, and depending on that, they predict that your lifestyle will be in the next 1 hour. You do like every day 10 a.m. you go for a walk, or evening time you do like this activity. Your further requirement will be there or not. So they predict your glucose level for next 2 hours, and that will also decide their insulin injection or the basal dose from this pump also. So that's how it is almost like an artificial pancreas.
Interesting. Thank you very much. That was a very illuminating, very illuminating. Thank you.
Thank you.
Dr. Saboo, is diabetes completely reversible?
So type 2 diabetic patients, the 25% of them who have developed because of obesity, because of their lifestyle modification, I mean, because of their bad lifestyle, they developed it. So if we modify their lifestyle, we change their completely and decrease their weight by 25%, many of them can have reversal of diabetes also. But this had happened only with newly diagnosed patients. I mean, someone who have developed diabetes, and maybe in next 2 or 3 or 5 years, if he does all those under medical supervision, he can reverse diabetes too. That's only for type 2 diabetes, not for type 1 diabetes.
Okay.
Can
And
I come? Can I
go
come?
ahead. Yeah,
Yes,
sure.
Gandhi.
सर अभी मैंने अल्ट्रासाउंड करवाया था. Okay, I'll talk again. I just got the ultrasound done, in which my kidneys are becoming shorter, 7.8 left and right. Does it have any impact on my health?
So diabetes patients में kidney का size change नहीं होगा. I mean, there will not be any effect if you have a diabetes kidney disease, but your size of the kidney may be slightly less, but still it is in a normal range, so nothing to worry for that.
Because I'm also 80 plus, that's what I thought.
I know, but nothing to worry about that.
That's nothing, but KFT is normal.
Yes, if kidney function is normal, then nothing to worry. Sir.
Right. Thank you
Okay.
very much. Right.
So I will take the last question from the same lady who asked for the pregnancy. She says, so since I have a temporary diabetes during the pregnancy, will that affect my child?
So if you are during pregnancy time, if sugar was remained very good under control, it will not affect your child. But if you had kept a sugar slightly higher level, then definitely it will increase the weight of newborn, and the child may have developed diabetes in his or her adult life, not immediately after the birth. So there's nothing to worry.
Okay, so I don't see any more questions coming up. I think it was a wonderful question answer round. Anybody else, if they don't have any questions, then we would like to wind up the session. Dr. Saboo has a flight to catch, and thank you so much for joining in from the airport and taking up this session at the last hour of your flight.
Thank you.
So with this note, I would like to thank all the members from CMAAO and International Medical Associations joining in over here, and some of the patients we invited today. So with this note, we would like to end the session with a thank you note. Dr. Saboo, would you like to give any take-home message to all our members?
First, I would like to thank IJCP, because increasing awareness is the only key by which we can have better control, improve control in the society, and some of the things like diabetes, which can be preventable and it can be prevented. So that's what wonderful program which you are doing. So thank you very much. And thanks to all those who could join on Saturday morning from different parts of the world, and particularly from India. Thank you very much. And I thoroughly enjoyed. I really enjoying this session even at the airport.
Thank you so much, and we will look forward for future more sessions from you, more knowledge. And I think technology is changing, world is changing, diabetic care is changing, the treatment are changing. There's a new lifestyle changes which are happening. People are getting into a different part of the things. So I think with this note, we would like to have a continuous education on the particular topic. With this note, we would like to thank you. Dr. Monica, would you like to say thanking words?
Thank you again, Dr. Saboo, and thank you, Saurabh. Thank you to IJCP and this platform. And I agree with you, Dr. Saboo. This is such a perfect way to spread awareness of topics that are very current and important. And we hope to see you again. Thank you.
Thank you, everyone. See you again for the next
Bye-bye.
segment.